rollout of the new Joint Commission measures for alcohol and tobacco-related inpatient care at the VA Pittsburgh healthcare system. This is being presented by Dr. Lauren Broyles, who is a full-time research health scientist and core faculty member at the VA Pittsburgh Center for Health Equity Research and Promotion, and she is also the core investigator with the VA's VISN for Mental Health Research, Education, and Clinical Center. She is a nurse investigator with advanced training in health research, health services research, and is the recipient of a 5-year VA Career Development Award. And her program of research focuses on expert in inpatient and primary care settings. So we will now start the poll questions, and then we will turn this over to Dr. Broyles. So first of all, people should see the poll question on their screen. Just indicate what answer is most appropriate for you. Are you from the counselor, therapist, social worker, or a counselor profession? Are you a nurse, nurse practitioner, physician, or physician assistant? Are you a program or unit administrator? Are you part of a student, faculty, or university student, or other? And if you'd like us to know what other is, just type in that information in the chat or questions box, and we will make sure that's in our records. We only have 5 options here for these polls, so I can't get into any more detail. Okay, thank you. I will now close this poll and we'll share the responses. Dr. Broyles in the audience today, 33% are counselor, therapists, or social workers. We have 13% nurse, nurse practitioner, physician. 13% also are program or unit administrators, and another 13% university student or faculty, and 27% other. That's a very varied group. I'm not used to seeing that, so this is wonderful. Okay, the second question is, what field do you represent? Are you in mental health, addictions, physical health, education, or are you EAP? Okay, thank you. I think that's a good representation. So we'll share those results. 7% mental health, 73% addictions, 13% physical health, 7% education, and no EAP. Thank you. These next 2 are going to be very quick because they're just yes, no. Do you currently conduct expert interventions? Yes or no? Okay, thank you. I will share these. 29% do conduct expert interventions and 71% no. And then our very last one is, does your agency use expert, or are they planning on using it? And just in case anybody doesn't know what that is, expert is screening, brief intervention, and referral to treatment. Okay, thank you. Okay, our attendee list today, 73% of their agencies do currently use expert or are planning to in the future, and 27% no. Okay, thank you very much for participating in that. Dr. Broyles, are you on the line?
Yes, I am.
Okay, I will now transfer this over to you.
Okay, thank you. Good morning, good afternoon. I really appreciate the opportunity to present today. This is the first presentation that we have done so far regarding our rollout of the new Joint Commission measures for alcohol and tobacco related care. So we're really excited to have this forum to present that and tell people a little bit about all the work that we've been doing behind the scenes and everything that's been involved. I was really pleased to hear that there are so many diverse groups of people represented, because I think that that really echoes one of my underlying messages that I'd like to convey today, is that this entire process of implementing processes of care in response to these types of measures really involves the entire spectrum, the entire team, not just the clinicians, not just administrators, but really the whole slew of stakeholders.
Excuse me, Dr. Broyles, did you click that little sign that said show my screen?
I thought I did. How about now?
There we go. Yes, thank you.
There we go. Okay. What I'd like to do is start out with some acknowledgments of my team in particular and some of the folks that have made this presentation possible today. First of all, my implementation team, I'd like to highlight Dr. Melissa Whelan, Dr. Monica DiNardo, Andrea Confer, and also Karen Mancini. These women are my wing women in this process. They're members of my research team as well as the quality and performance team here at VA Pittsburgh. I'd also like to acknowledge and thank the leadership of our institution, in particular our Chief of Staff, Dr. Ali Sanel, and our Associate Director for Patient Care Services, Dr. Ira Richmond, who is essentially our Chief Nursing Officer. I need to also acknowledge that I do have Career Development Award funding from HSR&D, which is Health Services Research and Development Service with the VA, and I'm also going to be talking about a little bit of work that we did also that involved pilot program funding from the VA Office of Nursing Services. I also need to point out that the presentation today is based in some work that was supported by resources, particularly at the VA here in Pittsburgh, and of course that the views expressed in the presentation today represent my own views and the work of my team, and not necessarily the policy or the position of the VA or the U.S. government. So as an overview for the things that I'm going to talk about today, I'm going to go over, for those of you who may not be familiar with these measures from the Joint Commission, I'm going to go over the main components of the measure sets for substance use and tobacco, just so that you understand what we've been charged with implementing. I'm going to talk very briefly about the 5 guiding principles that our team decided on when we went to begin formulating a game plan and moving forward with implementation, because these are really the undercurrents that have driven everything that we've done since January of 2014. I'm also going to talk a little bit very generally about the implementation theory that has guided our work. This field of implementation science is increasingly encouraging people to use implementation theory so that you're rolling things out in a systematic and thoughtful way that is based in the evidence, as opposed to sort of a haphazard kitchen sink type of approach. And then what I'm going to spend the bulk of the time on is going through the process so far, our implementation to date, and really focus on some of the facilitators and barriers to implementation of the measures that we have encountered along the way, so that you can think about which ones may be similar for your agency or facility or organization and which ones may be different. But the goal here really is to spawn your thinking about some of those facilitators and barriers that may be universal and some that may be organization specific. We definitely have some unique ones here at the VA, and I'm going to talk about those as well. So just to start out, give you a little bit of background on who we are. The VA Pittsburgh healthcare system is a large academic medical center in southwestern Pennsylvania. We are a major tertiary care center. We have 2 primary campuses with 661 beds, over 10,000 admissions each year, and approximately 5,500 surgeries per year. Our facility where I am located now is the University Drive campus, so it is in the main part of Pittsburgh where all of the universities are and the rest of the hospitals. And this facility does provide medical, neurological, psychiatric, surgical care, as well as transplant services and other specialized activities. We are also a major training center for disciplines for health professionals and allied health professionals from a variety of disciplines. So we have over 1,300 trainees a year in everything from audiology and speech pathology to pastoral education, healthcare administration, OT, PT, nursing, social work, podiatry. We're a major training center. We also have 8 advanced postdoctoral fellowships in everything from addiction to clinical simulation and patient safety as well. In addition to that, VA Pittsburgh is a major research hub within the VA. In fiscal year 2012, we had over $36.4 million in research activities going on, and that's both health services research, clinical research, and benchtop. So just to give you a little bit more background on where our institution and where VA in particular is coming from, VA does participate in an external peer review program. This is the official data source for monitoring VA facilities performance. The goal is to improve quality of care. So it's looking at these metrics, to understand what the priority areas are for practice change or system level change. So the data are used almost exclusively for quality improvement, internal evaluation, but then also benchmarking with external organizations like the Joint Commission. So Joint Commission's ORYX program folds together our outcomes as well as other performance measurement data into their entire hospital accreditation process. These requirements under the ORYX program are designed to help support organizations that are accredited by Joint Commission with their own quality improvement efforts. The data are publicly available on the Joint Commission website, and having this type of data available publicly allows people to compare hospital performances at the state and the national level. So most of you are probably familiar with Joint Commission, and if you're working in an inpatient setting in particular, you may be familiar with some of the core quality measures. A lot of that process is undergoing some changes right now as we speak, but in the past, for example, the core quality measures that hospitals had to report on were related to quality care, for example, in acute myocardial infarction, heart failure, pneumonia, as well as surgical care or surgical site infections. In 2012, though, the Joint Commission also released a new set of measures that hospitals could choose to meet their own 6 core measure set to receive hospital accreditation. And these measures were designed to address substance use and tobacco use in all hospitalized patients, irrespective of their admitting diagnosis or their clinical condition. So that means that any patient who's entering the hospital, whether it's for diabetes or a heart attack or pneumonia, is going to we are held accountable for addressing substance use and tobacco use with those patients. So what happened in VA was that effective January 1st, 2014, VA decided to adopt the new ORYX measure sets for substance and tobacco use. These went into effect January 14th for all VA medical centers nationwide. They remain optional for other healthcare systems outside the VA. These measures are similar to what VA already has right now in primary care as part of its EPRP program, but the change for VA is that we are now implementing them in inpatient settings, and they're not exactly the same as the existing measures that we have in primary care. And again, the notion here is that these are going to apply to all hospitalized patients. To give you a sense of what the measures involve and how VA Pittsburgh has operationalized them, I'm going to go through first a diagram for the substance use measures and then also for the tobacco use measures. So for the substance use measures, the first requirement is alcohol screening within the first 3 days of admission. If the person screens positive on the alcohol screening instrument and they would like us to use the Audit C, which is the short version of the audit, then they require brief intervention counseling. It's very similar to what a lot of you are familiar with. If the person also has an alcohol or substance use disorder, then some additional measures come into play, and those include referral to outpatient treatment, receipt of an FDA-approved medication for alcohol use or substance use disorder, and follow-up contact with the patient 15 to 30 days after discharge. So as a really brief nutshell, just so you know that where I'm going to be going with this talk, the way that we have decided to operationalize this here at VA Pittsburgh is to have the admitting provider, be it the nurse practitioner, the physician, or the physician assistant who is doing the inpatient admission either in the emergency room or when the patient hits the floor, would be doing the Audit C screening. If the screen is positive, that clinician will order in the electronic medical record a consultation for the social worker who will come and do the brief intervention counseling. This was decided upon because in VA Pittsburgh, social workers already see the patients on the inpatient unit, see all patients within 72 hours of admission. We needed a mechanism in order to have the patient properly evaluated for alcohol or substance use disorder. And so at this point, we decided to operationalize it that if the admitting provider detected or suspected a substance use disorder, or if the patient's Audit C score was greater than 8, which is highly correlated with alcohol use disorder, then they would also initiate a psychiatry consultation liaison consult. The psych consultant would come, evaluate the patient for a formal or proper diagnosis, make some recommendations for outpatient treatment, which the social worker would then implement, and also make recommendations for the admitting provider about any appropriate FDA-approved medication for alcohol use disorder or substance use disorder. I want to point out here, though, that these medications, I want to be very clear, these are not for acute withdrawal syndromes. These are medications like naltrexone, Suboxone, methadone, et cetera, for ongoing management of substance use disorder. And then finally, we're still working out the logistics of who is going to be conducting the follow-up contact with patients 15 to 30 days after discharge. This can take place in person or via telephone, and we're working out the process now where that would involve probably primary care nurses or licensed practical nurses conducting that outreach. Tobacco measures are very similar. They do also require tobacco screening within the first 3 days of admission, brief practical counseling, pharmacotherapy offered in the hospital to address acute withdrawal, referral to outpatient counseling or a quit line, pharmacotherapy again offered at discharge to help the patient with any maintain any cessation efforts, and then follow up 7 to 30 days after discharge. This is where our plan was operationalized a little bit differently. You may have noticed that nursing was not heavily involved in the original alcohol implementation, but this is our opportunity where nurses are really taking the lead with addressing the tobacco use measures, and I will be saying a little bit more about that in detail later. But in general, the nurse is screening the patient for tobacco use as part of his or her inpatient nursing admission assessment. The nurse is providing brief tobacco cessation counseling. The nurse and the provider work together to decide upon an appropriate pharmacotherapy for the patient if the patient is interested. The nurse provides the referral. Again, provider writes for the prescription at discharge for any additional pharmacotherapy. And then, again, it remains to be determined exactly how we're going to operationalize our follow-up piece. What I'm going to do is walk you through the timeline of how we arrived at those particular processes and really try to give you an idea of what was involved and how long different pieces take, again, so that you can have an idea of some of the major considerations that you may have to think about for your organization or facility and really be able to pace this out yourself. So briefly, just to sort of go all the way back to the beginning and talk very briefly about how I got here and how I became involved with this initiative. I am a nurse. My clinical background is in nursing, particularly in bedside nursing or staff nursing as a direct care provider on an HIV and infectious disease unit at the University of Maryland. I then left bedside nursing and joined the Substance Abuse Consultation Liaison Service at the University of Maryland. So at that point, I had an opportunity to travel across the hospital, which is also a major medical center, and help address acute withdrawal and treatment liaison services for patients across all domains of the hospital. And that's really where I started to have the opportunity to truly appreciate how ubiquitous substance use is, particularly among inpatients, and particularly the fact that there was just a lot of confusion and general lack of ownership around who was going to address this issue with patients, and too often it really got bumped to the back burner. I'm also an addictions health services researcher, so after I got my PhD in nursing, I did a fellowship in health services research here at the VA in Pittsburgh, and then stayed on as core faculty. My program of research really continued to focus on my clinical roots, which is addressing substance use in places like inpatient settings where no one is typically sure who's going to address what, when, where, and how. And some of the pieces of my research that have been particularly informative for this rollout have been some of my work in developing expert training for nurses, in particular, inpatient nurses, tailoring programs that speak to nurses and speak to their practice. I've also done a little bit of work in looking at hospitalized patients' acceptability of receiving expert in inpatient settings, particularly if it is delivered by a nurse. And we had also done some qualitative work talking with inpatient nurses specifically about the barriers and facilitators to incorporating expert into a typical day on their unit. So this combination of my clinical and research backgrounds are really what led Karen Mancini with Quality and Performance and the Chief of Staff to invite me into this role. So we started in fall of 2013, and this is really the phase that I just refer to as kind of getting our bearings and understanding the basics. We started as a core team before, right around the time that these measures were announced, around this time last year. The announcement was made that VA was going to be adopting these, and thought about what are really the core principles here that we want to make sure are guiding everything that we do. And the first is really that we wanted to be sure we had a commitment to interdisciplinarity. We really wanted there to be shared accountability for these measures and shared burden and shared growing pains as well. We know that sometimes these things tend to fall on certain disciplines, be it nursing, be it social work, and we really wanted this to be something that was shared, but also so shared in terms of burden, but then also shared so that people were all involved in sending the same message to patients to really increase the salience of that message. We wanted the process to also be participatory. We have always leaned more towards a participatory process as opposed to a top-down approach where people who are on the front lines don't feel like they have a voice or a say in what's going on. It was really important for us to have processes of care that remained patient-centered, that were really focused on why we're here, which is to serve the veteran, and to do that in a better way than we're currently doing. But at the same time, we wanted to make sure that the processes that we were developing were as efficient as possible for staff and really congruent with their current practice or their current workflow. This has been, I guess all of these themes are really knit together around the idea of meaningful metrics, which is something that our current facility director, Dr. David McPherson, feels is really, really important, that we can't get lost in the numbers, we can't get lost in performance measurement. We really, really have to be doing things that make sense and are informed by and are informing patient care. So our first task was really to establish the team, and what we did during the fall was to identify and invite stakeholders from a whole slew of different disciplines and service lines, and to then really establish a charter, which is a screenshot is included here. This is just the first page. There are additional details, and this was initiated by our Chief of Staff. And this, for us, was a really, really important step. It gave some formality and set of tasks for us to do. It gave us an official charge and laid out who was going to be involved so that there was a greater sense, I think, of formality and accountability, and the fact that we were being charged with a specific task and being expected to move forward and give regular monthly reports. When we were identifying who was going to be on our committee, we really had to think about any potential service line or discipline that was going to be involved. And so even though we we knew that this was going to focus on inpatient, we also needed to include the outpatient service lines who were going to be affected downstream. So we had representation on our initial committee from inpatient nursing as on the medicine side, as well as the behavioral health or psych side. We also had primary care nursing representation. We had representation from social work, again, on the inpatient medicine and psych side. We had physician representation, again, from those two sides of the house. Substance specialty treatment, our Center for Treatment of Addictive Disorders is right here at VA Pittsburgh, and that includes inpatient, IOP, and rehab. We needed to definitely have them involved because we were going to be having some downstream effects in terms of increasing the number of referrals coming into them. We also had representation on the committee from Quality and Performance, again with Karen Mancini. And then my team really represented research, and I'm going to say a little bit more about that a little bit later. But just to toss that out there, that it was both a pro and a con, that we were literally from another side of the house, literally from another building, and did not have a lot, the frontline stakeholder concerns in quite the same way that others did. Early in the fall, we also went back to the literature and took a look at the literature in three key areas. The first was what had previously been done in terms of inpatient SBIRT or inpatient tobacco cessation services. We also went and looked at the SBIRT implementation literature. We knew that there wasn't a lot that was specific to inpatient settings. So Emily Williams and Kathy Bradley in the VA have done a lot of work on implementation of screening and brief intervention into VA primary care settings, and there's been a lot of work done by other investigators across the world in this area. But there was very, very little guidance or instances of people using SBIRT, particularly in inpatient care settings. A little bit of work out of Australia and the United Kingdom. We also went to look at other implementation guides that are available, say, from the CDC for implementing SBIRT, or one of the newer ones from SAMHSA. But again, most of these guides had very strong general principles, but we were really concerned that there were going to be some differences in implementing this in the inpatient setting, that it was different than primary care or it was different than emergency and trauma, and really had a lot of difficulty finding that literature. We made that case back in the fall when the opportunity came up for some end-of-the-year fiscal money that the VA was looking to share. VA Office of Nursing Services had some pilot funding available. And what we really said was, let's tack something on to our existing implementation so that we can start to provide some of that very practical guidance about how you roll these out. Some of our previous work, as well as some other work that had been done in the VA, really highlights the fact that outpatient and VA and non-VA primary and emergency care implementation of SBIRT is really, really tricky, even in the presence of guidelines and initiatives that are tailored to those settings. And some of my earlier work has suggested that different factors like patients and workflow and cultural differences between the inpatient and the outpatient settings could really impact implementation, as well as a lot of inpatient clinicians' ambivalence about addressing alcohol and substance use or doing health promotion activities in the acute care setting. We thought that all of that contributed, and we really wanted to get a sense of what really to track and then share the experience of our interdisciplinary team who was being tasked with implementing SBIRT in a setting where it hadn't been done before. So we decided to conduct a formative evaluation of our own rollout. Formative evaluation is a research method that's commonly used in implementation science, and it focuses on what are the methods for promoting the practical translation of evidence into clinical practice. In this study, oops, I'm going to jump ahead, our goal was to really identify what our stakeholders' implementation needs and preferences were before we implemented SBIRT, and then we wanted to be able to apply those strategies in real time. So the specific aims of our study were to look at the factors that were required to initiate implementation of the measures, get them up and running on 2 inpatient units at our facility, 1 medical surgical and 1 psychiatric, and then also to assess the factors associated with sustained implementation of the measures on 2 inpatient units. So you can see here on the current slide I have PRECEDE and PROCEED marked, and that's really to give a clue back to what our theoretical model was that was driving this. PRECEDE-PROCEED is an implementation model. We're using the first part of that for this implementation to really identify, I guess in many ways you could think of it as a fancier or elaborated form of facilitators and barriers. We wanted to understand what some of the predisposing, reinforcing, and enabling factors were going to be during the rollout, before the rollout, during the rollout, and after the rollout. So predisposing factors are the factors that are associated with a person's motivation to undertake a new behavior. They include someone's knowledge, attitudes, their beliefs, their self-efficacy, any existing skills or preferences that they may have. The other thing that goes into the mix is reinforcing factors. These are things that follow a behavior or an activity that reinforce someone continuing to do it, continuing to be persistent or repeat it. And these include things that are a little bit more external to the individual, so social or professional support, recognition, and peer influence or even vicarious experience. And then enabling factors, which we also wanted to identify, are what are some of the other things in that external environment that make it possible for people to change their behavior. And this includes programs or resources or services, again, in that organizational context or milieu. So going back to the aims for a second, you can see that we wanted to capture what are the sets of factors that go into being able to launch this, and then what are the factors that go into being able to sustain it. For this study, which is, again, an add-on to the initiative, we're doing 30-minute audio-recorded interviews with clinicians, administrators, and patients from each of our 2 units where we're going to pilot this implementation. We're doing them at 3 time points, before, during, and after implementation. We've also done 8-hour unit observations so that we can get a sense of what the unit norms and culture and processes of care and how much interdisciplinary collaboration is going on. And then we're rapidly analyzing these transcripts to inform the implementation in real time. So essentially, during the fall, this is what we did. Got a lay of the land, got an understanding of what we were going to be charged with doing, organized a committee, and then received this supplemental funding that really helped give some structure and organization to our game plan, what we were going to do moving forward. January to March, that first quarter of 2014, is really the time, though, that we got a large lay of the land in terms of what the task was that we were going to be faced with doing. VA held a national call with all of the performance measurement professionals to give some very general information about the measures. At the time, the offices within VA were undergoing redesign. So there was a point person for these measures, but at the time there was extremely limited infrastructure support. This isn't an unfunded mandate. There's no funding or other support associated with the rollout. And there were no centralized hub of resources or strategies available. It was really the sense that each facility could tailor their implementation the way that they wanted, and that they encouraged us to share ideas, but there really wasn't any top-down guidance in that sense. There was also a plan to pilot some electronic medical record templates that people could use across VA, but due to, again, some of the internal changes that were happening in these offices, that also got put on the back burner. So what the purpose of the call was really for us to understand the measures, understand the definitions, understand the skip patterns, and all of the details that are built into them. What I want to point out again, given that I just referred to research a few moments ago, is that what we decided was that we were going to have 2 things going on simultaneously. In the orange, you see the implementation, the rollout of the activities, figuring out the who, what, when, where, and how of we were going to meet these measures. That really falls under, in essence, quality improvement. At the same time, we had the formative evaluation of the rollout that I just mentioned, and that fell under research. We had both going on at the same time, but what I'm going to be focusing on today is really the implementation itself. Some of the things that we also had to figure out at this point were really getting a sense of who our players were going to be on the task force, who was going to actually respond to the invite, and who else we needed to have on board. So despite the initial set of stakeholders that I showed you in terms of our committee, we also quickly realized that we were going to need to have representation from the clinical informatics team, the team that runs the electronic medical record, and we were going to also need to have representation from a former substance abuse consultation service that had been here at VA Pittsburgh but had been absorbed under behavioral health. So the major task that we focused on during those first 3 months was really getting a sense of what are the existing processes of care that we have going on that we could springboard off of. What are we currently doing in terms of screening? What are we currently doing in terms of talking about substance use? How do we currently do referrals? We also wanted to get a sense from each service line or discipline that was represented on the committee what people's existing concerns were and what they anticipated as being barriers. Each service line had to have the opportunity, both in a group forum as well as individual sessions when we met with them, to really be able to talk about their fears, because this was going to be a major change. We did not have major processes like this put in place. Every service line typically feels like they're stretched to the max and their clinicians are already juggling multiple balls in the air at one time. And so the notion of taking on something else or additional responsibilities can be really, really scary, and it was important for everyone to be able to voice that. We also knew that we needed to get a sense of what the existing resources were within VA. So what kinds of tobacco cessation packages or interventions were available? What types of consultation services were available? Who was doing what? We all tend to be rather siloed across service lines, and so it really meant a lot of reaching out and sharing of information in our first 3 to 5 committee meetings, just really trying to get a sense of what's going on. And all of this together was intersecting during our meetings. We would have some initial brainstorming, which would then fuel some concerns. We'd have initial brainstorming and realize we were duplicating existing resources, which was good. And then, so there's this constant interplay and really trying to wrap our heads around what this was going to mean once we actually started operationalizing this stuff. Once we had our charge, we knew what we had to springboard off of. We also had to organize ourselves as well as our tasks in order to get things done. And so we needed to decide on some initial structure and roles. Were we going to take on this task by unit, by behavioral and medical units, since we were going to pilot this on just 2 units first? Did we want to tackle it and carve things out by measures, by alcohol versus tobacco? Did we want to break things out by the actual activities that were going to be involved? Screening, brief intervention, referral to treatment, the pharmacotherapy, and the follow-up. And who were we missing? Who else were we missing? And this is really the point at which we realized, again, that we needed to bring the electronic medical record people into the fold. We needed to have them present at every meeting. We needed to have psychiatry consults. We needed to have outpatient, more outpatient nursing and nursing leadership representation. And we needed to eventually divide out according to activities. So we had an initial subcommittee structure where we had a screening committee, a brief intervention committee, a referral to treatment committee, and then a follow-up committee. And that really helped us break things out into tasks where people could join the committee that most matched what their stakeholder interests were. So for example, some of our outpatient behavioral specialty substance abuse folks decided that they wanted to join the follow-up committee or the referral to treatment committee because those were the ones that were most likely to impact them. So at this point, we're ready to springboard. We're ready to launch. We have some ideas. We're ready to set them in motion. We're ready to get started, and had done this initial brainstorming. But what we realized really, really quickly was that the person or entity driving the bus here was going to be CPRS, which is our computerized patient record system, or our electronic medical record. VA has had an electronic medical record for quite some time. They were pioneers in this area. And what we realized is that we not only needed CPRS to guide some of the documentation of these activities that we were going to be doing, so that Joint Commission or our own EPRP system could come in and take a look and see how we were doing, but that we also needed CPRS to really guide and drive some of the processes themselves. So for example, if you think back to when I was mentioning how the admitting clinician in the ER who's doing the workup for the patient would be administering the audit C. You know, we envisioned that we wanted the CPRS system to auto-score that audit C and then prompt the clinician to order a a social work or a psychiatry consult based on that score. We wanted the scores to be electronically beamed to those departments, generate a list or however they wanted it to look so that then they knew which patients needed to be seen for what. We wanted, all of this is theoretically possible within the electronic medical record system. However, because different templates within CPRS have different functionalities, because the nursing template, for example, doesn't necessarily electronically speak well to other templates, we soon realized that there were a whole myriad of restrictions and limitations in CPRS that were going to affect what we could and couldn't do and how we were going to design these processes of care. I'm going to stop for a moment and take any questions up to this point before I move on.
I'm showing 2 people have their hands raised, so we will see if they really mean it or if it was a mistake, which it generally is. So hold on just a moment. Okay, Tasha, you had your hand raised, which indicates to me that you want to be unmuted. Would you like to speak to Dr. Broyles? Okay, well, I can't hear you, so if you would, you might need to dial in the toll-free number. So I will mute you again. Okay, so that means at this point, I don't have any questions from anybody.
Okay, so I'll move into the next phase, which was really spring into early summer. And this is the phase that we sort of refer to as cycling. I'll get to that in a moment. The first thing that we launched pretty quickly were the study interviews that I mentioned. We wanted these interviews, again, to be informing our rollout in real time. We wanted information from the front lines, from clinicians and administrators who were not involved in our committee, as well as patients, so that, again, we could fulfill those commitments to patient-centeredness as well as clinician workflow and administrative concerns as well. This was really important for us because although I had done only a little bit of work in the area of patient acceptability for SBIRD on the inpatient side, we really know that patients had had some uncomfortable experiences talking about substance use with clinicians, and we weren't sure how amenable patients in general were going to be to talking about these types of issues or health promotion type issues when they're in the midst of an acute admission. We also wanted to get their sense of what the best way would be, or their preferences about how and when people would be talking with them about this. Would they prefer for it to be in the emergency room, or once they hit the floor, or a couple days into the admission? How would they prefer people to speak with them about this? Did they have preferences about who they'd feel most comfortable speaking with about these types of things? And so this was really important. We launched these interviews for the pre-phase pretty quickly. We then launched into really what happened as a series of false starts in terms of processes of care and CPRS templates. Again, with CPRS really restricting some of the ideas that we might have. So we might get up to a flow chart here in our committee. We would start to decide on an initial process and just realize that CPRS was not going to be able to order consults or trigger alerts or speak to the outpatient side of the house in the way that we had desired. And certain considerations that we also had to include were whether or not in different templates or in different spots in CPRS, the data were going to be extractable for the reviewers. So it really took our committee and our stakeholders about 4 to 5 months to really begin to wrap our heads around what this mandate was and that it was here to stay. For the committee, again, hearing concerns and hearing barriers and objections was critical. Most of the stakeholders, as we went out across service lines at the hospital to talk with others or to do these interviews, we realized that most stakeholders had not heard about these measures at all. We were the initial messengers. And as soon as they realized the full impact of what the measures might mean for their service line, most people became more invested, but then often raised new concerns or new barriers and sometimes pulled back. So in many respects, what we were doing was cycling around trying these different pathways here on the flow chart and really trying to branch out from what we as a committee thought were going to be really great ideas, representative as we were, and really making sure that we were engaging with the front line. Thinking back to our substance use measures, at this point we had an initial plan here with the admitting provider. Our original goal was to springboard off some processes of care that were already in place. So in the VA, nurses are familiar with doing formalized screenings, whether it's screening for skin integrity, whether it's screenings for tobacco use. They had not been previously familiar with doing the Audit C in particular, but the whole screening process was already built in as part of their typical admission process and their admission templates in the CPRS system. So at first it really felt like a natural fit. But there were some initial concerns that came from our chief nursing officer as well as some other nursing administrators about nurses typically being really bearing a lot of the responsibility for measures like this and really having the exclusive accountability for these. The thought was really that so much kept getting inserted into that initial nursing inpatient assessment that it was really becoming kind of a catch-all and was making it really difficult for nurses to move efficiently through that process. At the same time, we were encountering technological difficulties on the CPRS side because, as I mentioned earlier, the nursing template was developed at a separate time from some of the other templates, and they just didn't speak well to one another. So in terms of efficiency, in terms of being able to initiate these consults quickly and in a timely manner, especially given decreased lengths of stay, we got the idea from one of the clinical informatics nurses to consider having the admitting provider do the Audit C. And this was really a shift. Most physicians are not oriented towards using screening instruments. It's typically not a part of their practice. And we really wanted to be mindful of the fact that when patients are being admitted, they're maybe in a particularly acute time in terms of pain or discomfort, and we weren't entirely sure if that was the best time. So we were looking at issues of efficiency and training and sustainability. We also had to keep in mind that we are a teaching hospital, and most of the house staff are rotating through at any given time. How are we going to realistically train all of these admitting providers? And then we had to look really at the issues of oversight and documentation and communicating the rest of the process. So we developed 2 plans for how this could be rolled out from a physician-driven process from screening forward and how it could be rolled out from a nursing standpoint. We took that to our chief of staff, discussed it with him, and he was actually very supportive of having this be a physician-driven process, both in terms of efficiency, in terms of shared burden and accountability, but also in terms of being able to respond and initiate these processes in a timely manner and not have to have, for example, nurses, chasing physicians down to order certain consults or follow up or take care of things. So even though our chief of staff was immensely supportive of physicians taking on this role, there was some skepticism and some ambivalence about that role being assigned to physicians. The medical executive board here at the VA did approve that, but there were concerns from both physicians and house staff about needing to take on this role. And there were also concerns from nursing, who felt like screening is really what they did best. And they were disappointed that this role had been removed from their scope of practice. And some nurses had concerns that physicians weren't going to do it and that they would be ultimately responsible for doing it anyway, so why not just start with nursing? So at the end of June, this is really our state. We're 6 months into the process. We had this physician-driven game plan for the substance use measures, and we had some folks who weren't happy or comfortable with it. We had these partial spinning plans or parts of processes of care where we had some things hammered out but not others, and everything is really connected by or impeded by the limits and capabilities of CPRS. And so we get so far in figuring out, say, up here of who is going to do screening and how that was going to happen. We would get so far over here in terms of starting to figure out where the follow-up was going to happen and who was going to make these telephone calls or who was going to ask these questions to inquire about the patient's use status and whether or not they were taking the pharmacotherapy that had been prescribed, et cetera. And we started to feel like we were spinning our wheels. At this point in time, our group, my own team, decided to initiate monthly calls with other VA facilities in our region or in our network, which is known as a VISN. Our VISN is VISN 4. It includes all of Pennsylvania, part of West Virginia, and also Delaware. And so we started convening monthly meetings to really share stories, share ideas, figure out if our challenges and our dead ends were similar or were different. We were all part of the same VA system, but of course some of us are large academic medical centers like Pittsburgh and Philadelphia. Some are smaller community-based hospitals, and we really needed to be able to get ideas from each other where maybe our size or our resources were slightly different. But in general, at this point in June, we had some half-finished processes of care. We're waiting for various approvals from the Executive Leadership Board and the Medical Executive Board and the union and the Nursing Clinical Leadership Council, which is part of their shared governance model. And at this time, we had heard everyone's concerns. We had heard everyone's issues and barriers. And this is really the point of the 6-month mark where we knew we needed to make some decisions. There wasn't going to be a magic bullet or answers from others in the VISN. We felt better and validated that many of the other facilities were experiencing some of the same concerns that we were, but ultimately there really wasn't going to be magic answers at the national or the VISN level. We just needed to decide on a plan and take a leap of faith. So moving into the summer is really the phase where we decided we got some help prioritizing what we needed to do next, and then really began plowing forward. This is really the point where my team met with our Chief of Staff, Dr. Snell, to let him know what was going on, where we were in the process, and really we breathed a sigh of relief when he really gave us some very pragmatic and clear guidance around being able to prioritize and move forward in this from this point. We knew that we had to stick to our pilot. Our goal was to pilot these measures on 2 units, get a flavor for what they would need to look like on behavioral health and medicine before we scaled up to the rest of the hospital, critical care, surgical, and some of the other short stay units. He encouraged us to stick to the pilot and really consider a phase-in process. what happened was that we were getting caught up a lot in a lot of the details. The more we talked to different stakeholders, the more that we were hearing about outliers or unique issues that certain service lines were going to encounter. And his encouragement was, let's consider this pilot, phase 1, where we're going to develop a process to address 85% of our patient flow. The remaining 15% we're going to save for phase 2. That would include what we're going to call the outliers or some of these unique issues. One of the biggest sticking points for us, and I'll say more about this later, is really this issue of opioid-dependent patients. Our current process of care was for those patients to be initially seen by their admitting clinician, while they're in the hospital, but to have a referral to our Center for Treatment for Addictive Disorders upon discharge. So it may be you're being discharged today, you have an appointment at the CTAD Center next Tuesday, and at that time, the substance use specialist would do the full ASI or the full intake evaluation and really determine what level of care you needed or what services or pharmacotherapy. We really struggled with how we were going to implement either methadone or buprenorphine for those patients. We also were hitting some sticking points around this 3-day parameter within the measures themselves. So our concern was, what are we going to do about critical care patients who maybe are ventilated or sedated for the first 3 days of admission, and then they're transferred to a medicine unit? How are we going to make sure that electronically, when they hit the medicine unit and they're now extubated and alert and can speak, how are we going to make sure that someone is now, asking them these screening questions, and how are we going to make all this electronically happen? And those are just 2 examples of things that Dr. Snell just encouraged us to put on the back burner or put on the parking lot for now, and really just hone in on the main process that was going to get us up and launched. So we decided to try that and go from there. One of the second things that we did in this phase, now that we had decided that providers were going to be the ones doing the audit C, is that we started to pilot the CPRS templates. We wanted to make sure, again, that whether we're talking about physicians or nurses or social workers, that we had CPRS templates that people could use that were efficient and fit their workflow. So we started working with our VIRC, which is the Veterans Engineering Resource Center, which is a group of industrial engineers and systems analysts here at the VA who really look at workflow redesign. And they helped us do some think alouds with physicians who were going through the pilot, literally thinking out loud as they go through it, letting us know what their perspective was from a user about how well did this fit your workflow, how intuitive was it, how easy would this be to learn. And that really gave us, again, additional insider view and window into the mind of the person who would actually be on the front lines executing these processes of care. We also, during this time, again, early summer, started moving full force into training. So we needed to train providers in how to administer the Audit C, even though it's a 3-item questionnaire. Again, they weren't familiar with it. They had not previously been using a lot of screening tools, were not familiar with the importance of reading the questions and the response options verbatim, not peppering it with additional comments or questions that may lead the patient to respond inadvertently in a certain way. We also needed to think about how we were going to train our social workers in brief intervention. So although the social workers already had this skill set in general, and many had been trained in motivational interviewing, for example, their psychosocial assessment primarily focused on patients with substance use disorders, so folks who are already meeting criteria for a disorder, and their conversations, they told us, tended to focus more on engaging those patients to consider or pursue specialty treatment. What the measures are asking us to do, though, is to widen our lens and respond to patients who may be hazardous drinkers or risky marijuana users. And so the social workers told us that they would need some help in framing motivational discussions for those types of patients, because they were used to only dealing with folks with heavier substance use involvement, and that it just really wasn't in their orientation to address some of those more moderate use patterns. We also needed to be sure that the social workers were going to be including the 3 elements that the Joint Commission was considering a brief intervention. And those 3 key elements were that you had to provide normative feedback about the patient's level of drinking. You had to discuss or explore any social, legal consequences, etc., and then discuss the overall magnitude of someone's drinking. We also needed to train nurses in the tobacco tactics program, which I haven't said a whole lot about, but I'm going to. The tobacco tactics program is the way that we were choosing to implement the tobacco measures. And we went back and forth on this. The reason that I've kept it out of the presentation until now is because it kept sort of popping in and out of our process itself. On the one hand, we felt like we really wanted to get the alcohol measures underway and solidified and then add the tobacco, but at the same time we knew that the behaviors themselves went hand in hand, and we knew that if we were going to need to go through the process of training and modifying the electronic medical record and changing processes of care, it would probably be easier to do all at once. So while our primary charge was implementing the alcohol and substance use measures first, we also had the tobacco engine going on the side as well. And then finally, in terms of training, we were developing and ordering materials. This card probably looks very familiar to most of you. Most folks who have been involved with SBIRT have some sort of similar tool that they use. This is what we actually developed, a laminated pocket card that Andrea Confer on my team developed that physicians could keep in their pockets so that when they were at the bedside, they could remember the audit C, standard drink, etc. So at this point, I'd like to say something briefly about the tobacco tactics program. And in particular because, again, this is where we had the opportunity for nurses to really take a lead and be a part of owning the tobacco process and really driving that. Nurses felt that this was a set of measures that they were more comfortable addressing. It was something that many of them were already addressing with their patients in some way, shape, or form. And so we decided as a committee to try out a program known as Tobacco Tactics, which was developed by my colleague, Dr. Sonia Duffy, at the Ann Arbor VA. This particular package is an evidence-based program that was designed with veterans, and there is literature that's available on its design, its efficacy, its effectiveness, as well as its implementation in psychiatric and inpatient medical settings. The entire program was developed over time to be responsive to the Joint Commission measures, and so we felt like it was while those measures were being developed, and so we felt like this was going to be a really good fit, and it's what we decided to go with during the pilot. The package itself has a clinician toolkit as well as a patient toolkit, and by and large, the process mirrors the measures themselves. So the first step in the behavioral protocol is to assess if the patient is interested in quitting. If they are interested, let me back up. If they're not interested, then a brochure is left with them that has some general information about stopping smoking. This is the brochure that Sonia was gracious enough to let us modify. She shared all of her materials, all of her evaluation tools, all of her articles, everything with us, and we modified this to be usable at VA Pittsburgh. It had previously been used at the Dayton, Ohio VA, the Ann Arbor VA, several VAs and non-VA settings in Texas and Chicago as well. The next step in the process is that if the patient was interested in stopping smoking, leaving the brochure, but also arranging for the patient to view the corresponding DVD. This is one from a company called Milner Fenwick called Smoking, Getting Ready to Quit. And the idea here is that the wheels are essentially greased for the nurse to have this kind of conversation with the patient and introduce some of the basic information about setting a quit date, nicotine replacement, etc. This way the patient could watch the video either on a portable DVD player or over the television network with the patient education channel that we have here in the VA. And that would set the stage for the nurse to come back and do the next part of the required measures, which is using the manual to do the brief counseling that would cover some of the key areas that Joint Commission requires. So in particular, handling cravings, handling stressful or trigger situations, and then also I'm drawing a blank on the third one. Okay, there are 3 key components that need to be included in that counseling as well. Dr. Duffy does have a tobacco tactics workbook that she also provided to us. She had extra copies available, and we're using those during the pilot. You can see some of the table of contents. The booklet has a number of small, short exercises for the patient to do and engage in, and really the nurses can take the 9 to 11 minutes to go through and hit some of the key points in terms of what the measures are asking to be included in the counseling. You can see also that she has included new information on smokeless tobacco and e-cigarettes, so that we're really addressing all the different types of tobacco that our patients may be using. The next step in the process is to, along with the patient, identify and arrange for nicotine replacement or cessation therapies. There is a chapter in the booklet on this, and also guidance for the nurse on how to have a shared decision with the prescriber about which medications may be appropriate for the patient based on how much they smoke and what they've tried or had success with in the past. And then finally, the nurse is also responsible for making sure that follow-up calls are taking place. The Tobacco Tactics Program, or the booklet, is entirely available online. You're also welcome to try that out using this test information, which we can make sure is available. So this provides an additional option for veterans or patients who may be more tech-savvy or not have issues of visual impairment. There is also a tobacco tactics version in terms of the booklet, and I'm not sure about the website, but definitely the booklet that is available for non-VA settings as well. At this time, we continue to work on tobacco tactics templates in CPRS, working directly with the nurses. How do you want to see this documented? What's going to work for you? What pieces are going to talk to other pieces? How do you want to be able to, in essence, electronically talk to nurses on the outpatient side? The nurses in our facility decided to model these templates after the patient education templates that they had used for congestive heart failure. We also began working with nurses directly, champions on the unit, to design an evaluation plan based on some of the metrics that our Chief of Staff and Chief Nursing Officer had asked us to obtain in terms of nurses' receptivity to this program, patients' receptivity, and then the actual measures themselves. What we also did during this time as a committee was start to come back to this issue, which was the elephant in the room, of how are we going to handle these follow-up contacts. What we've heard by and large is that for the most part, this follow-up piece of these measures is what is the sticky wicket or the monkey wrench for most organizations that are considering this. It's a big question of who's going to do this, exactly how, and when. Who is going to have ownership over these once the patient is discharged? In our facility, some of the people that we considered were registered nurses in primary care, the LPNs in primary care, who again did most of the screening. We had the option to potentially do it with medical support assistants or clerks who could be making these telephone calls. We also considered peer volunteers. VA Pittsburgh was recently selected as a site for a new chronic disease self-management program that's partially funded by Strength to Serve as well as AmeriCorps, and VA was going to be training peer veteran volunteers to help with chronic disease management, and we thought, well, could that be folded in as well? We also have to consider, at least in our VA, the issue of multiple calls that are being made to veterans. So in an integrated healthcare system like VA, we're already, for example, making calls that are mandated 48 hours after discharge for veterans to be followed up on after they've had a hospitalization. And that time frame doesn't match up with the 7 or the 15 days for these two measures. So there were some concerns about patients already receiving multiple follow-up calls after a discharge from their primary care team or from the facility. There's already, in some cases, a difficulty getting a hold of veterans, and we really worried about the workflow burden not only for primary care clinicians who were making these telephone calls, but also just the annoyance factor for the veteran, who could be getting anywhere from 3 to 5 calls for different VA issues or resources or performance measures or what have you. So I want to move quickly sort of from here on to the end so that we have some time for questions, and just kind of bring you up to where we are now from the early fall. We realized that we could not limit the pilot by unit. We had to do it by service because patients are actually admitted to a service like Team A, Team B, or the hospitalist service or whatever, as opposed to a unit. We've been finalizing the training plans, getting nurses trained in the tobacco tactics program. Sonia Duffy trained us. We were doing a train the trainer model where she trained us via VTEL or video conferencing, and then we have started training nurses on the psychiatric unit and the med-surg unit in how to do this. We've also handed a lot back over to our committees. In many respects, we ourselves as the leading team had taken on too much and really turned that back over to the heads of the screening, brief intervention, and referral committees, and really helped let them, again, take more ownership. Moving forward, we're still shooting for an October 20th launch date for the pilot. We're going to try piloting these measures on the processes of care that I've discussed on these 2 units for 2 months, and kind of look at our metrics, look at what's working, look at what's not, and then decide what changes we need to make before we roll up to the rest of the hospital. We're still trying to finalize some of these electronic medical record templates. Some of them can be modified at the local level, but some need to be modified at the national level. And for us, that creates some unpredictable time frames. And then still we're working through exactly how the follow-up calls and contacts are going to be taking place. What could happen at the mandatory visit that veterans are supposed to have within 2 weeks of being discharged from the hospital, and how does that overlay with the required time frames? If those patients don't have an appointment or they don't show, then figuring out how we're going to contact them afterwards. Overall, we've had a number of thorns in our side. You've heard me mention CPRS or the electronic medical record many, many times. It's both a blessing and a curse. One of the other thorns in our side has been just really getting clarity on interpreting and clarifying the measures. We know that the measure developers, invested so much time in developing and piloting these, but they can't think of every possible contingency or every possible way that these play out in real life. And so once you actually start thinking about them, a whole slew of new issues come up, and we just need to constantly go back and clarify with our leads on the VA side about how these are to be interpreted. The other thorn in our side is that all of us are doing this in addition to our normal clinical research and administrative responsibilities. So, all of those things need to sometimes take precedence, and it just can be difficult kind of making it all fly within a typical 8-hour workday. We had some initial trouble with sporadic meeting attendance at our committee meetings until people really, I think, became engaged and figured out what their piece of this was going to be to own. Overall, we've had a number of just summer vacations and illnesses right as we were trying to work through and get through all of these processes. And that created confusion and problems not only on our own committee, but because many of the approvals for the things that we needed to do depended on monthly meetings of these various committees or the union or the executive leadership board for this or that. And so what happened was we would be ready to go, but we needed to wait, say, until the end of the month to move forward because we needed committee approval. Some of the specific hurdles that we as a team had to overcome, these are a little bit different than the ongoing thorns on our side. One of the biggest hurdles was that this was an unfunded mandate, and we had initially received limited guidance and resources. We really needed to pull together what we knew based on our own research and clinical experience, what we had here at VA Pittsburgh, and then look around the VA to see what else might be available from other VA entities, whether it was the Health Promotion Division or the Office of Mental Health Services or some of the other substance use specialty entities in the VA. There wasn't a one-stop shopping where we could go and say to a website and look and see, oh, okay, well here are some packages or strategies or implementation ideas that we could use, and let's pick and choose. It was really a lot of behind-the-scenes sharing that was going on. Additionally, these are really complex measures. They're emotionally loaded or socially loaded in a way that measures for heart failure aren't. These are measures that had multiple parts, involved multiple services and stakeholders and disciplines across the entire continuum of care, and really, again, that people in general just have different levels of comfort and ambivalence around addressing substance use. And so all of that was potentially complicating these rollouts. I've mentioned that we're already busy clinicians and researchers and just had to make time for this because it's an immediate thing and it's a mandate that our accreditation depends on. And I also mentioned the layers and layers of approval. In any kind of situation like this, you have general politics and personalities involved that just are sort of par for the course. And we had the mixed blessings of being outsiders. On the one hand, my team being researchers or being performance measurement, we had we ourselves, not just the larger committee, but those of us at the helm, had the luxury of not being involved in, say, some of the ground level politics or issues that the frontline stakeholders were. But at the same time, because we weren't, it meant that we had to build trust and buy-in with them. I've mentioned the potentially taboo topic that we've had, and that we took on the rollout of the substance use and the tobacco measures at the same time, which again, to some extent there was some synergy there, but on the other hand, it really doubled what we had on our plate. I don't want to leave the impression, though, that we were entirely faced with barriers. We actually had an outstanding number of facilitators that have really come into play, and I want to give some attention to those quickly as well. I mentioned the outsiders, that sort of paradox of both blessing and curse in being outsiders. I've mentioned CPRS, and I've also mentioned the substance use and tobacco measures and the synergy that kind of went along with that as well. My team, because my research had focused on some of the inpatient units where we were doing this, we had some existing relationships with those nurses and those administrators in particular that really helped expedite that trust and buy-in and partnership. We also had a designated and responsive clinical informatics staff who have been immensely helpful in really working through the details and the weeds with us. We did not have to barter or bargain for their time. They came on board, again, with the Chief of Staff's approval, and we are just immensely grateful to them for helping us think through all the different permutations of what needs to happen electronically. We also had immense administrative leadership support and buy-in. I can't say enough about that. That has made all of the difference in greasing the wheels, getting some of the approvals that we needed, and just really having the support to think through a lot of those weedy issues with us, as well as the 30,000-foot view. They were also the ones responsible for chartering our committee, which gave formality to that, and just a sense of rootedness and grounding. We had our own team who was dedicated to an effective rollout, and also had champions who had special interests or skills in this area. So people for whom tobacco cessation or substance use was a personal issue because they themselves were in recovery or had family members who were. Or we had, for example, one of our champions on the medical unit is in a clinical nurse leader role, where it was really part of his envisioned role for him to be helping with implementation of evidence-based practices. And then finally, I'd really like to give a shout out to Karen Mancini, who is our performance measurement person on the team, who really understands the value of meaningful service delivery. There's the possibility always that you're going to have someone at the helm on that side who is all about the metrics, all about the numbers, all about the measures. And Karen is just a fantastic partner who really wants to make sure not only that we're meeting the metrics, but that we're doing it in a way that's clinically and ethically responsible and keeps the veteran first. We had some existing processes of care that we could springboard off of. As a large medical center, we do have a psychiatry liaison service. We were familiar with tobacco tactics and benefited from Sonia's generosity. We here at my research center had some in-house data experts that could help us with some of these evaluation procedures. We had initiated these a network-wide SharePoint and calls to share ideas and really just know that we were sort of all in this together and we're experiencing some of the same barriers. And we also in some ways had a little bit of luxury of time because we had a recent Joint Commission visit. So we knew that we probably weren't going to be formally evaluated again soon, even though, of course, they can stop by at any time. In closing, this is muddy and messy work. As soon as you're talking about real people and real budgets and real staffing on the front line, it's muddy. Some days you're spinning your wheels in the mud, and other days you're on a roller coaster ride where there are just weird twists and turns. You're either creeping along or you're racing faster than you want to go. Leadership support for us was critical, as was genuinely engaging with people, asking good questions, being willing to hear their concerns and problems, and putting your own agenda off to the side so that people really got the sense that you understand their perspective from the front line. And that takes a lot of energy, and it takes a lot of time. We knew that this whole participatory process takes time, but moving faster, we were worried about risking buy-in and sustainability. So for us, it was really an issue of pay now or pay later. But we had to decide how much we wanted to make top-down decisions, how much we wanted to continue to get consensus and input, and how often we just needed to move ahead. And then the sixth lesson learned is really about expecting these seesaws and these tensions, these balancing acts between staff efficiency and being patient-centered, this balance between engaging your stakeholders and having buy-in and participation from the frontline clinicians or administrators, and needing to move forward in time with time constraints. And then again, that notion I alluded to a few moments ago of good clinical care versus just meeting the measures. Whoops. Okay. So the most exciting thing for me in closing is really that as a health services researcher, this is a chance for us to bring research back to practice. It's a chance to have my research as well as Sonia Duffy's cycle back and inform practice in the way that we've always wanted it to. So even though this is messy and complicated work, it's also really part of that tricky translation process. And it's really exciting for us to have the opportunity to be a part of that. I'd like to just recognize my core committee, and again, you'll see the variety of disciplines here. And with that, I will stop and take questions. And please, if we have, I guess, about 6 minutes left, but if we run out of time, please feel free to contact me. My VA email address is lauren.broyles, B-R-O-Y-L-E-S, at va.gov, and I'd be happy to talk with you, or someone from my team would be happy to talk with you about some of the additional details and nuances.
Great. Lauren, thank you so much. That was wonderful and contained so much information. I've got a couple questions here, and the first you actually answered during the webinar, and that was, what do you do with patients that are not ready to, or state that I don't want to give up my cigarettes and or alcohol? And you had a brochure that you said you gave to people, or that was handed out to people who said that they just weren't ready. And if you could just email me either that PDF or a link to it, I think it would be really helpful for people who have questions like that.
Sure. If I could just say a little bit more about that too. You know, I've been oriented, you know, in a motivational interviewing and stages of change kind of model. So we really wanted to respect the fact that patients may not be ready, but that we were part of a larger process that maybe would be continued on the outpatient side as well. The measures do allow patients to refuse to be screened. They allow the patients to refuse to be intervened upon or counseled or receive referrals or receive medication. So that's always an option for patients. But we did want to design the brief intervention response as well as all of our screening responses and information sharing responses so that we were respectful of the state of change that the person may be in.
So that'll be great, because I did have a question about that. And then also somebody else asked for you to please post the link to the Tobacco Tactics Manual again.
Oh, sure. So the online version of that, definitely.
And again, you can just send that to me, and I will be sending out an email to all the attendees with a link to the recorded session, and then we'll work on getting your PowerPoints, and any of the other information that you can supply will go out to everybody who's attending this session. Let's see, here's another one. These are coming in now. Are you aware of efficacy regarding templated interventions for patients in various stages of change?
No, I'm not. That's actually a great question. One of the things that we had tried to develop in, so there are a couple different things. So there are computer-assisted brief intervention tools that are available. I'm not sure if that's what the person is asking about, or if they're asking about something that would be embedded in the EMR that may walk people through what to say to patients. We actually had done a little bit of pilot work on that very question in primary care, because we were interested in whether or not clinicians would use that, whether or not it would give them enough flexibility and not be perceived as cookbook medicine or a robotic sort of script, but that would cue and give them an idea of at least key points that they could hit during a discussion. What we found is that by and large physicians were not interested in having a tool that was that structured, but that nurses and LPNs were. So I guess the answer is it depends on what the person's asking about, if they're thinking about a computerized BI tool or something that would guide them through.
Yeah, this says it's embedded in the emergency room.
Oh, embedded in the medical record.
Yes.
No, I'm not. We had, that was our goal, to develop that. I would be interested in talking with anyone who is familiar with that or is in the process of doing that.
Okay. Let's see, here's another one. What is the best resource for a new Joint Commission measures for ESPR?
So is the question sort of about like a one-stop shopping sense of what the measures themselves are, or for what resources are for rolling them out? So I can also provide you with those links as well. They are publicly available, what the measure specifications are. So you will be able to see, for example, what each of the measures are, what the definition is, what counts as a yes, what counts as a pass-fail, and then what those definitional issues are as well. So I can provide you with those links as well, Chris, to send out.
Yeah, that'd be great. And then let's see, we have one more here, and I think somebody wanted to be unmuted. But this last one is, how are patient family members included in the process to address patient substance and tobacco use?
That's a really, really great question. And that's something else that we had actually thought about and bumped into phase 2. One of the thoughts was that, you know, a lot of the nurses, for example, often said, you know, the patient isn't ready, but the family member will come to me and say, you know, I need some resources myself, or, you know, he's been thinking about quitting smoking, what can we do? And so the thought was that we were going to have, in particular, some of the tobacco cessation materials and quit line cards and other things available on the units, so that they'd be available for family members to maybe take home and either approach the patient with themselves or approach at a time when things were just generally more settled and the patient was more physiologically and stable, and that those resources would be available. The Tobacco Tactics Program in particular has generated a lot of interest on the surgical side of the house, who's really interested in looking at tobacco cessation across the continuum of care. And they've been really interested in having these materials available, like the video or the booklet, just in waiting rooms and other things where family members could pick them up. We have not thought as much yet about how families could be involved in the screening or referral processes for substance use, though.
Okay, well, let's see, I don't have any more questions. And so we can close now. I will email you to get those the links and the references that we discussed. And then tomorrow everybody will get an email from me with that information in it, and as well as the evaluation that we need everybody to complete, please. It's the way we can keep these free and keep them going. And so I think at this time we can close this session. Thank you so much, Lauren, and thank you everybody that attended.
Thank you.
Okay, bye-bye now, everybody.